TOG 2024 Issue 4. Urethral Caruncles. Solved CPD and SBA questions are at the end of the video. Introduction. A urethral caruncle is the most common benign tumor of the female urethra, accounting for 90% of urethral masses in postmenopausal females. It is rarely observed in premenopausal women, and there is only one case report of urethral caruncle occurring in a male. The average age of presentation is 68 years. It is usually an incidental finding in which a soft pink or red polypoid nodule is noted to protrude from the distal urethral meatus, Figure 1. They vary in size but are typically under 1 cm in diameter. Presenting symptoms include dysuria, dyspareunia, and bleeding, although approximately 1/3 of patients are asymptomatic. Figure number 1. Varying appearances of a urethral caruncle. The eversion of urethral transitional epithelium was first described in 1750 by Samuel Sharp. Despite being a known pathology for over 2 centuries, urethral caruncle remains a poorly recognized condition owing to the nature of its appearance, and it can be frequently erroneously referred to secondary care as a potential malignancy. However, the overall incidence of malignancy in a urethral caruncle is low. The reported rate of carcinoma following excision ranges from 1.6% to 12%. Etiology of urethral caruncles. The female urethra is a tubular structure approximately 4 cm to 5 cm long and 8 mm in diameter. It lies between the urethral pelvic ligaments, where proximally it is lined by transitional epithelium and distally by non-keratinized stratified squamous epithelium. The outer layers consist of a complex network of smooth muscle and vascular structures. Microscopically, urethral caruncle consists of vascular connective tissue loosely surrounded with transitional and squamous epithelial cells. Histologically, it is composed of a hyperplastic benign epithelium with inflammatory infiltrate, in particular polymorphonuclear cells, and tufts of capillaries in a stroma. Depending on the state of inflammation, vascularity, and fibrosis, there are 3 subtypes of urethral caruncle: papillomatous, angiomatous, and granulomatous. Furthermore, reactive patterns, such as fibrocapillary proliferation, granulomatous, hypervascularity, angiomatous, epithelial hyperplasia, papillomatous, or intestinal metaplasia, mucinous, can be observed. Immunohistochemistry for immunoglobulin G has been shown in a subset of patients, suggesting a possible autoimmune factor. The precise etiology and pathogenesis of urethral caruncles remains mainly theorized. As the main predisposing risk factor is being of postmenopausal age, and as it is believed that urethral prolapses are a result of estrogen deficiency, a hypoestrogenic state may contribute to the development of urethral caruncle by a similar mechanism. Decreasing estrogen levels lead to urogenital atrophy and lack of support of the surrounding smooth muscle, which causes the urethral epithelium to become more susceptible to prolapse. Chronic irritation of the then exposed urethra can lead to the formation of caruncles. This theory is further supported by the histological findings of chronic inflammation. Other proposed mechanisms are chronic inflammation or irritation of the urethra from factors such as ruptured Skene's ducts or urethritis. Congestion of the urethra, infection, and trauma have also been proposed as possible etiological factor. Clinical presentation of urethral caruncles. Urethral caruncles may present with multiple symptoms. Box 1. In a clinical and histopathological review of 41 patients with confirmed urethral caruncle on presentation to secondary care, 1/3 of patients were asymptomatic, 32%, and it was an incidental finding on vaginal examination. When present, the most common symptoms are dysuria, 20%, pain, 37%, and hematuria, 27%. Typically, it may present with bleeding or spotting noted on underwear or upon wiping, which is mistaken for vaginal bleeding. A urethral caruncle usually presents as a pink or red, fleshy, exophytic lesion of less than 1 cm in diameter that is effectively a single quadrant urethral prolapse. Typically, they arise on the posterior margin of the external urethral meatus and do not obstruct the orifice. They can be pedunculated or sessile, are generally highly vascular, and are disposed to thrombosis, so on rare occasions they may look purple or black. Urethral caruncles can cause dysuria, but they are an unlikely cause of voiding or storage symptoms. In patients with incontinence, it was found that those with a urethral caruncle did not report any difference in lower urinary tract symptoms or have different findings on urodynamic studies compared with incontinent women without a urethral caruncle. However, large urethral caruncles, which were mistaken for a genital prolapse, have been described in case reports as a cause of acute urinary retention. Cases of urethral caruncle in children have also been reported, with only 14 case reports in the English language literature to date. The mechanism is believed to be due to chronic inflammation. A urethral caruncle should be differentiated from other urethral lesions. Clinical differential diagnoses include carcinoma in situ, urethral diverticulum, erythroceles, urethral polyp, varicosities, condyloma, and cysts of Skene's glands. A variety of other urethral lesions have been described that mimic urethral caruncles and include urethral melanoma, tuberculosis, lymphoma, urethral leiomyoma, and urethral carcinoma. A few case reports describe the rare occurrence of a squamous cell carcinoma in a urethral caruncle. Unusual presentations of interstitial cystitis, vaginal wall cysts, vaginal leiomyoma, and Gartner's duct cyst abscess and pelvic inflammatory disease should also be considered. Table 1 provides a summary of differentials of urethral caruncles. Traditionally, urethral caruncles were described as extremely painful, with patient descriptions such as scalding, cutting, and burning attributed to them. However, recent case reports have suggested they are usually painless lesions but can cause discomfort if forming a polypoid mass or when ulcerated. Box 1. Presentation of urethral caruncle. Dysuria, dyspareunia, hematuria, vaginal mass, vaginal bleeding, pain, vaginal discharge, urinary tract infection, rarely urinary retention. In the non-cancerous category of lesions, there are 7 differential diagnoses. First, urethral caruncle. It presents as 1 cm lesion in a single quadrant, on posterior urethral meatus, red or pink in color, purple or black if thrombosed. Caruncles are friable, soft, smooth lesions with fleshy appearance. Second, urethral prolapse. Prolapses are smooth, red with donut circumferential appearance. Third, urethral polyp. Polyps are pedunculated lesion, more common in children. Fourth, periurethral, Skene's gland, cyst. These cysts are smooth, round, fluid-filled lesion at urethral meatus. Fifth, urethral diverticulum. They present as an outpouching of the urethra with a narrow communicating neck. Sixth, Bartholin's cyst. These present as cystic mass lateral to urethral or vaginal introitus, as a fluid-filled swelling. Seventh, condylomas, which present as warty skin growths around the urethra due to HPV infection. In the malignant category of lesions, there are 4 differential diagnoses. First, urethral carcinoma. It presents as a regular, friable mass around urethra. It may be hard to touch with palpable lymphadenopathy. Second, bladder cancer. Papillary tumors may prolapse through urethra. They are reducible. Third, urethral leiomyoma. It is nodular tumor protruding from meatus. Fourth, vulval cancer. It presents as an ulcerated lesion arising separately from urethral meatus. Investigations. A urethral caruncle is a clinical diagnosis on physical examination, and further investigation is unnecessary in the vast majority of cases. A thorough examination involves close inspection and palpation of the lesion, accompanied by a routine speculum and bimanual examination, especially if vaginal or postmenopausal bleeding is a presenting symptom. If there is any suspicion of malignancy, the inguinal lymph nodes should be examined. Further investigations will depend on individual patient symptoms. This may include urinalysis and microscopy and culture to exclude an infectious element. When the source of hematuria is unclear, or malignant pathologies need to be excluded, investigations to consider include flexible cystoscopy, rigid cystourethoscopy, ultrasound, or computed tomography or hysteroscopy. For more complex urethral lesions, ultrasound can help distinguish urethral caruncle from other solid masses. On ultrasound, urethral caruncles are hypoechoic or isoechoic and rich in blood flow signal. Pelvic sonography to exclude endometrial pathology should be considered, if appropriate. especially if the presenting complaint is postmenopausal bleeding as an endometrial thickness of 4 mm or less has a greater than 99% negative predictive value for endometrial cancer. If indicated, MRI can aid exclusion of underlying malignancy where they appear as T2 hyperintense tissue surrounding the external urethral meatus. If there is any suspicion of a malignant pathology, tissue biopsy of the urethra is advised. Management of urethral caruncles. Conservative management. Provided there is no concern for malignancy, the majority of urethral caruncles can be managed conservatively. Approximately 1/3 of urethral caruncles are asymptomatic and these can be managed with no intervention, depending on patient preference. Medical management. The mainstay of treatment is with low-dose topical estrogens with pessaries or topical creams. The management is often complemented with sitz baths and topical non-steroidal anti-inflammatories or steroids for additional symptom relief, though there is limited evidence for their effectiveness. Patients often notice improvement in symptoms within 6 weeks of initiating treatment with topical estrogens, though maximum effect of therapy is 3 to 6 months. A systematic review of the literature on urethral caruncle management reveals mainly retrospective case series and small cohort studies, with no randomized controlled trials to date. The traditional focus is primarily on surgical excision. Surgical management of urethral caruncles. Surgical intervention is rarely required and is largely reserved for urethral caruncles that remain symptomatic, despite treatment with topical estrogens, or where diagnosis is uncertain, for example owing to atypical appearance. Surgical excision may also be considered for thrombosis, significant or recurrent bleeding or acute urinary retention. Best practice dictates that excision should be undertaken by a urogynecologist or a very experienced gynecologist or urologist. The most common method of surgical management is simple excision. This is usually performed as a day case procedure, under general anesthetic, with placement of a urethral catheter for 48 to 72 hours post-operatively. Local practices and surgeon preferences will vary. Below is an outline of the key principles when undertaking surgical excision of a urethral caruncle. The key surgical steps include: 1. Prophylactic antibiotic dose in line with local hospital guidelines. 2. Cystoscopy followed by placement of a Foley catheter to reduce risk of clot retention. 3. Use of stay sutures in the proximal epithelium to prevent mucosal retraction and meatal stenosis. 4. Excision of the lesion. 5. Oversewing the edges with 3-0 or 4-0 absorbable sutures, like Vicryl. 6. Trial removal of catheter at 48 to 72 hours postoperatively. An alternative surgical management technique is the ligation method completed under local anesthetic, whereby a ligature is placed at the base of the caruncle allowing it to atrophy and fall off. Urethral caruncles can also be removed by cauterization and laser vaporization. Potential risks of surgical excision include clot retention leading to urinary retention, meatal retraction, stenosis, infection, wound breakdown, and recurrence. One case series of 41 patients reports a recurrence rate of 7%. All patients should be fully informed of these potential risks, as they may prefer to avoid surgery. No specific follow-up guidelines exist for patients who have had surgical removal of a benign urethral caruncle. However, best practice would suggest advising long-term use of low-dose topical vaginal estrogens post-surgery to prevent recurrence, with no routine follow-up necessary. Malignancy. The diagnosis of urethral caruncle can be a challenge owing to the variety of differential diagnoses. The exact incidence of caruncles containing carcinomas is unknown, with one reported rate as 1.6%, while a further study reported that 12% of excised caruncles contained carcinoma. The malignant differentials include urethral carcinoma, bladder cancer, and vulval cancer. Primary urethral carcinoma is rare, more commonly it is spread directly from the bladder, or the prostate in men. The most common primary urethral malignancy is squamous cell carcinoma, the remainder are transitional cell carcinoma, adenocarcinomas, sarcomas, or melanomas. Bladder cancers are most commonly transitional cell carcinomas, TCC. They can prolapse into the urethra and therefore may be reducible. Bladder TCC commonly have a papillary appearance, often described as resembling a coral reef. Their distinct appearance is therefore usually rather different from a urethral caruncle. Vulval cancers, although close to the urethral meatus, arise separate to it. They usually appear ulcerated and irregular. Malignancy should always be considered if a urethral lesion looks atypical. Where there is any doubt, patients can be referred to secondary care via the 2-week wait suspected cancer pathway. Advice for primary care. An incidental finding of a urethral lesion in a postmenopausal patient should raise the likelihood of a benign urethral caruncle. However, if there is any concerning appearance to the lesion, which is not in keeping with a benign mass, e.g. bleeding to touch, irregular hard appearance or with palpable pelvic lymphadenopathy, the patient should be referred on a fast-track urological malignancy pathway to allow exclusion of carcinoma. If there is any uncertainty but absence of sinister characteristics, consider referral to the local 2-week wait or gynecology advice and guidance service. Clinical photography, especially if a referral is being made, should be considered. For postmenopausal or perimenopausal patients, consider trial of vaginal estrogen for 6 weeks and review. A suitable regime, for example, would be a pea-sized amount of topical vaginal cream or pessaries to be applied, used daily for 4 weeks, then alternate days for 2 weeks. If there has been an improvement, continue with maintenance twice-weekly application with no indication for cessation. Encourage the patient to self-monitor the lesion and practice good vulval care. There is no indication for long-term review if the patient remains asymptomatic with no concerns regarding the appearance of her urethra. If there has been no clinical change despite trial of vaginal estrogen, consider secondary care referral as a routine referral. Encourage the patient to continue vaginal estrogen. If there has been the development of red flag symptoms or irregularity of appearance, consider urgent referral. Conclusion. Urethral caruncles are a common finding in the postmenopausal urethra that should not cause consternation. Familiarity with their appearance should provide reassurance that it is a benign lesion with low malignant potential. Trial of vaginal estrogen should be considered for the majority of patients prior to referral to secondary care. However, in patients who are symptomatic or when malignant change is suspected, urgent referral to gynecology or urology should be considered. Pause to read the CPD and SBA questions.